Welcome to the Radiographics Podcast, brought to you by RSNA. I'm Wendy Gibbs. This week on the podcast, we have two great summaries. Dr. Frederick discusses MRI perfusion techniques, and I'll share an interesting article about global outreach and education. Let's start with MR perfusion.
Arterial Spine Labeling, Techniques, Clinical Applications, and Interpretation. I really like the principles of ASL. Learning about them forces you to think about the physiology of the brain and different disease processes, so reading this article helped me connect a few dots I didn't realize needed connecting. Cerebral perfusion is the process of blood delivery to the parenchyma through a network of vessels, allowing the exchange of oxygen and other molecules. It can be imaged using different methods such as MRI, CT, PET, and SPECT. MR perfusion techniques include dynamic contrast enhanced imaging, dynamic susceptibility contrast enhanced imaging, or DSC, and arterial spine labeling, or ASL. We will be focusing on ASL, an emerging non-invasive MRI technique for assessing cerebral perfusion. But first, let's briefly touch on perhaps the most commonly used perfusion imaging method, DSC. DSC requires intravenous injection of a gadolinium-based exogenous tracer to assess cerebral perfusion parameters such as relative cerebral blood flow, or CBF, relative cerebral blood volume, time to maximum perfusion, and mean transit time. DSC is widely accepted because of its fast acquisition time and relatively robust signal intensity characteristics owing to the high relaxivity of gadolinium. The main disadvantages of DSC are the requirement of an exogenous tracer and its semi-quantitative nature. ASL is an emerging non-invasive MR perfusion method that is based on the use of magnetically labeled arterial water protons in blood as an endogenous diffusible tracer. A major advantage of ASL is that no contrast agent is required, allowing its use in patients with contraindications or adverse reactions to gadolinium-based agents. This also makes ASL an attractive and safe alternative for children and for patients who require repeated follow-up imaging. Over the last decade, advances in MRI technology and pulse sequence design have translated ASL beyond the research arena to successful clinical implementation. However, ASL is still underused in routine clinical practice. Some disadvantages of ASL include a lower signal-to-noise ratio and a longer acquisition time than those with DSC. So how does ASL work? ASL uses labeled water protons in the blood and feeding arteries outside the imaging plane. The label is obtained by combining radiofrequency pulses and gradients to reverse the longitudinal magnetization of the water protons in the labeling slab. The subsequent post-labeling delay is a critical period of time during which magnetically labeled blood protons flow into the microvasculature and tissue. During image acquisition, labeled and control paired images are acquired. The labeled image demonstrates the inverted blood proton magnetization, and the control image shows non-inverted blood proton magnetization. Pairwise subtraction of the labeled and controlled images eliminates the static tissue signal from the parenchyma and provides the signal intensity of perfusion-weighted images, which is related to CBF. The ASL signal is affected by several parameters, including labeling efficiency, T1 relaxation in arterial blood, blood transport time through vessels and tissue, and magnetization transfer effects. The labeling effect of ASL is weak, and therefore multiple repetitions of labeled and control paired images are required over several minutes to ensure a sufficient signal-to-noise ratio. However, repetitions promote artifacts, including patient motion artifacts. During ASL acquisition, multiple labeled and controlled paired images are acquired, and the CBF data are averaged to generate an absolute CBF parameter and a visual CBF map. The post-processing of ASL data requires several steps, such as pairwise subtraction of labeled and control images, motion correction, segmentation of the T1 weighted image, and calculation of absolute CBF maps. Because ASL is a low signal-to-noise ratio technique, the recommended field strength is 3 Tesla. Using a single value of post-labeling delay is recommended as a standard clinical protocol. However, multiple post-labeling delays may aid in some situations, such as in slow flow conditions where it takes more time for blood to enter the capillary beds of the brain parenchyma. So before we know how to interpret ASL, we need to know what normal ASL brain perfusion looks like. The posterior cingulate and central and posterior precuneus cortices show increased ASL signal intensity. The occipital region may show increased ASL signal intensity because of activation of the visual cortex. Relatively increased ASL signal intensity in the frontal lobe is usually seen in young and middle-aged adults and decreases with aging and the presence of cardiovascular risk factors. The globus pallidus may demonstrate decreased ASL signal intensity, probably because of iron-induced T1 shortening. Decreased ASL signal intensity can occur in areas extending from the anterior frontal horn to the frontal cortex and from the posterior lateral ventricles to the parieto-occipital cortex, corresponding to the arterial border zones or watershed zones. This condition is usually seen in elderly patients, particularly those with atherosclerotic carotid or intracranial disease. Images of pediatric patients typically show a high signal-to-noise ratio and a globally high absolute CBF, which are mainly related to their higher baseline CBF, faster mean transit time, and higher T1 values in blood and tissue in comparison with those in older patients. CBF is low in the perinatal period and progressively increases, reaching maximum levels when patients are 3 to 8 years old. It then gradually decreases until reaching the adult level. And then a rather depressing fact, from approximately 30 years of age, there is a progressive reduction in gray matter perfusion. ASL perfusion is prone to several artifacts that can make interpretation difficult because of degraded image quality or the introduction of pathologic mimics. However, artifacts can also provide additional information that can be used in diagnosis. These artifacts can be classified into 3 groups on the basis of the phase of imaging in which they arise: during magnetic labeling, during arterial transit, or during the readout period. ASL artifacts are not always detrimental. In certain cases, they help to support a presumptive diagnosis by increasing the conspicuity of specific processes. For example, the intra-arterial ASL signal from arterial transit artifacts is potentially helpful in indicating a delayed arterial transit time and possibly a cerebrovascular disorder. An arterial transit artifact that is confined to a specific vascular territory may indicate a stenotic occlusive disease of the supplying artery, while a global arterial transit artifact suggests diminished cardiac output. In addition, a trapped ASL signal may indicate entrapped turbulent flow in an aneurysm sac, manifesting as high signal intensity on a CBF map, increasing its conspicuity. ASL venous signals may aid in the diagnosis and post-treatment follow-up of high-flow vascular shunting lesions such as AVMs, dural AVFs, and cavernous carotid fistulas. ASL may also be useful in the detection of jugular stenosis with retrograde reflux into the sigmoid sinus. Let's move on to the clinical applications of ASL as they pertain to different types of disease, starting with vascular disorders. Cervical internal carotid artery stenosis may be asymptomatic or may manifest with a transient ischemic attack, stroke, or ocular ischemia. ASL can contribute to the evaluation of patients with these disorders, allowing quantification of CBF. Arterial transit artifacts can occur when the CBF has a transit time longer than the post-labeling delay, meaning the labeled blood does not reach the parenchyma during image acquisition, resulting in the persistence of labeled spins in the intraarterial compartment at the time of imaging and manifesting as increased intraarterial ASL signals. Arterial transit artifacts may be associated with border zone artifacts, which correspond to low ASL signal intensity in the brain area distal to the arterial transit artifacts, because the labeled blood has not yet reached the parenchymal capillary bed for tissue exchange. It is important to emphasize that arterial transit time is influenced not only by cervical carotid stenosis, but also by carotid output and intracranial stenosis. In patients with unilateral internal carotid artery stenosis, the study of hemodynamic status must include consideration of delayed anterograde flow of the ipsilateral internal carotid artery and collateral vessels. Clinical studies have used multiple post-labeling delays with transit time correction to improve the quantification of CBF. A transient ischemic attack corresponds to a transient episode of neurologic dysfunction resulting from focal cerebral ischemia without permanent infarction. Approximately 30% of clinically diagnosed transient ischemic attacks demonstrate diffusion-weighted MRI changes, and perfusion abnormalities may be seen on ASL images. A substantial number of patients who have had a transient ischemic attack showed no diffusion-weighted changes at MRI, but may show low ASL signal intensity. In patients who have had an acute ischemic stroke, the infarct core represents the already infarcted parenchyma and manifests with restricted diffusion and decreased CBF. The ischemic penumbra represents hypoperfused tissue that is at risk for infarction, but is potentially salvageable if reperfused. A perfusion-diffusion mismatch is the discrepancy between the area with low CBF and the smaller restricted area representing the penumbra. Studies have reported significant agreement between ASL and DSC and detection of the penumbra, although ASL tends to overestimate its extension. A recent study showed that including ASL in routine brain MRI in the hospital setting can provide additional findings compared with conventional brain MRI in the setting of cerebral ischemia. Luxury perfusion is blood flow in excess of metabolic requirements to the infarcted brain and is thought to represent a state of localized dysautoregulation that is associated with breakdown of the blood-brain barrier. It may be present as focally increased ASL signal intensity in the affected parenchyma. High-flow vascular malformations such as AVMs and dural AVFs have direct and rapid passage of blood from arteries into veins. Digital subtraction angiography remains the standard for diagnosis and follow-up after treatment of these arteriovenous shunts. However, ASL can improve non-invasive detection by uncovering venous ASL signal artifacts, manifesting as increased signal intensity in the veins, because the labeled arterial water reaches the venous site early and without exchange of tissue water through the capillaries. ASL can aid in the follow-up of treated arteriovenous malformations by revealing the location of the nidus of the AVM. Obliteration of the nidus after radiosurgery is usually delayed, rarely occurring before 2 or 3 years after treatment, so prolonged follow-up may benefit from use of the non-invasive ASL method. Quantification of ASL CBF of the nidus may improve objective monitoring of the obliteration of arteriovenous malformations after radiosurgery or partial embolization. Most arterialized developmental venous anomalies are not associated with perfusion variations. However, a minority may show high signal intensity on the ASL map that is related to a direct arteriovenous shunt in dilated medullary veins, and they have been reported in the literature as arterialized DVAs. Now moving on to tumors. MR Perfusion has important clinical applications in the diagnosis and evaluation of central nervous system tumors and can help differentiate them from non-neoplastic lesions, assessing biologic aggressiveness and tumor extent, assisting with planning for surgical biopsy or resection, and evaluating treatment response. DSC is the most clinically used perfusion technique in the evaluation of brain tumor. However, ASL has advantages including the lack of requirement for an exogenous tracer and quantitative CBF measurements unrelated to blood-brain barrier disruptions, while DSC reports values related to tumor blood volume and vessel permeability. Quantitative ASL measurements have been reported as helpful in distinguishing between high-grade gliomas, which show high tumor blood flow due to neovascularity, and low-grade gliomas, which show low tumor blood flow. The presumptive diagnosis of central nervous system lymphomas is essential for adequate therapeutic planning, mainly to avoid a more aggressive surgical approach, because the patient may benefit from a combination of chemotherapy and high-dose radiation therapy. Lymphomas may be indistinguishable on images obtained with conventional sequences, but usually do not show substantial microvascular proliferation. Primary lymphoma of the central nervous system demonstrates primarily angiocentric growth and the absence of florid neoangiogenesis, resulting in slightly elevated perfusion values that are much lower than those found in high-grade gliomas on images obtained with DSC and ASL sequences. Hemangioblastoma is a highly vascularized low-grade tumor commonly seen as a cystic lesion with an enhancing mural nodule or as a densely enhancing solid lesion, frequently containing flow voids in the posterior fossa. Hemangioblastomas demonstrate high tumor blood flow, reflecting their well-known pathologic feature as a network of exuberant vessels, with slightly higher tumor blood flow values than those of gliomas, meningiomas, and schwannomas. The evaluation of treatment of high-grade gliomas is a major challenge, especially in distinguishing radiation-induced necrosis from recurrent tumors in patients with new or increasing areas of enhancement. ASL can help with this differentiation because radiation necrosis demonstrates low CBF, whereas most recurrent tumors demonstrate high CBF. ASL has been reported to have a diagnostic performance similar to that of DSC and PET for distinguishing tumor recurrence from radiation necrosis. Meningiomas are hypervascular tumors that are commonly supplied by dural arteries and to a lesser extent carotid and vertebral branches. Given the hypervascular nature of these tumors, preoperative embolization may contribute as an adjuvant treatment in selected cases to decrease the technical difficulty of surgery and to maximize the rate of complete resection. Both the relative CBF from DSC and tumor blood flow from ASL are correlated with angiographic vascularity and help to distinguish meningiomas with low and high vascularity. ASL images can also be used successfully to differentiate hypervascular from non-hypervascular lesions in the base of the skull. Distinguishing meningiomas from schwannomas in the cerebellopontine cistern is not always simple with conventional sequences. ASL may help by demonstrating a higher tumor blood flow in meningiomas than in schwannomas. The same principle can be applied in the differential diagnosis of tumors in the sellar and parasellar regions, in which pituitary adenomas show low tumor blood flow, while meningiomas show high tumor blood flow. Now briefly touching on ASL in dementia and neurodegenerative disorders. In patients with dementia and neurodegenerative disorders, hypoperfusion and hypometabolism often precede anatomic abnormalities, such as atrophy. Therefore, ASL or metabolic imaging such as PET may provide imaging biomarkers for early diagnosis. ASL reflects neuronal activity and may demonstrate findings similar to those at PET or SPECT. Alzheimer's disease will show decreased CBF in the posterior cingulate gyrus, precuneus, parahippocampal gyrus, and hippocampus. Frontotemporal dementia will show lower ASL signal intensity in the frontal cortex and insula compared to Alzheimer's disease. In conclusion, ASL perfusion has great potential for broad clinical use, and its adoption is gradually increasing. Therefore, radiologists should become familiar with ASL techniques, the potential artifacts, and the wide variety of clinical applications. Knowledge of ASL findings in patients with different neurologic disorders and the development of practical guidelines and approaches by neuroradiologists will further enable integration of ASL into clinical practice and its broader acceptance among neurologic communities.
Development of a computer-based radiology curriculum in conjunction with Zambia's first training program. The World Health Organization estimates that 2/3 of the world does not have access to diagnostic imaging. Aid to the developing world in terms of imaging resources often comes in the form of equipment or financial support. However, this approach is limited in its utility without radiologists to manage the acquisition and interpretation of images generated. A critical component of any effort to develop sustainable radiology in resource-limited settings is to build capacity for self-sufficient radiology practice, including local radiology training for local physicians. In Zambia, where only 8 radiologists serve the entire population of over 18 million people, too few local radiologists and large workloads leave little time for activities outside of routine clinical duties and insufficient bandwidth for the Zambian radiologists to develop and implement a postgraduate training program. At present, efforts to establish new postgraduate radiology training programs in resource-limited regions tend to occur in isolation, often limited to a partnership between the host institution and an established training program. Global radiology education is a small sector in which relatively few people are involved. It's difficult for these individuals to collaborate because they're often working in low and lower middle income countries or other resource-limited settings that are not well connected to the greater radiology community. The idea for Practera, a portable radiology curriculum for training, evaluating, and retaining radiologists in Africa, was to package educational materials being developed for the Zambian trainees with plans to make them available to other programs looking to establish training programs of their own, thus bridging the gap in communication and collaboration between developing radiology training programs. The primary goal of Practera is to create a computer-based, content-rich curriculum that can be easily accessed from anywhere in the world and provide a framework and guide for a postgraduate training program, reducing burgeoning programs' reliance on outside support. The organization of Practera is based on the curriculum of a typical American diagnostic radiology residency and subspecialty society recommendations, made relevant for resource-limited regions by focusing on readily available imaging modalities and considering endemic disease and basic treatment options. The authors recognized that constrained available technologies and access to few qualified teachers would be issues that they could not necessarily solve, but problems to consider as they developed content. They minimized the need for specific supplementary texts and study materials, but the intent was for this program to be used in tandem with other available teaching resources. The authors were awarded the RSNA Educational Research Development Grant in 2018 to develop Proctera. The initial concept comprised the following components: a case library to include examples from each radiology subspecialty, basic technical instruction, radiation safety and troubleshooting, trainee evaluation, and dissemination. The initial plan was to disseminate the case library on a website that hosted a DICOM viewer to access and view cases, from which trainees would dictate case reports. Technical instruction was to include educational videos demonstrating how to perform commonly encountered sonographic and fluoroscopic examinations, and radiation safety training would comprise a basic set of recommendations and troubleshooting tips. Trainees would be evaluated on the basis of generated reports, as well as periodically assessed with multiple-choice case-based testing. The development of Proctera was planned and implemented by U.S.-based radiology residents, uniquely positioned to develop the program because they're acutely aware of what works for their own training. Meanwhile, the Zambian trainees provided feedback on the utility of the developed material via their own opinions, as well as metrics of their performance, as a way to test the developed material. Based on this feedback, and due to several challenges over the last 3 years, including the worldwide pandemic, there were several challenges to the program. The case library DICOM viewer proved to be less than ideal because of unreliable internet and local data streaming capacity. So instead, they opted to develop a website where all educational materials could be downloaded for offline use. Further, they intended to have a large portion of cases collected from Zambia to reflect the endemic diseases and imaging protocol capacity. They compiled approximately 1,000 cases, mainly from the University of Rochester, but collecting an adequately proportionate number of cases from Zambia proved to be more challenging. These challenges propelled them to shift from developing a case library to developing topic-specific flipped classroom approach learning modules as the main driver of the curriculum. Each of the modules is a case-based set of images and questions intended to guide the learner to identify the relevant findings and to highlight important concepts for a specific topic. Currently, the program contains 50 unique learning modules containing 356 cases, and expansion of these modules is ongoing. The main challenge in this approach has been the transience of the American radiology residents, whose primary obligation is to their own training. Therefore, they increased the involvement of the Zambian trainees, who are integrated into learning module development, with more senior U.S. radiology residents overlooking and checking the modules for correctness and clarity. They also shifted to development of focused modules rather than comprehensive learning materials, alleviating the burden of specialty expertise. The shift to the learning module format provided an unexpected venue for learning by inadvertently facilitating an extreme version of the flipped classroom. It also provided an integrated evaluation tool that could be used for self-guided or instructor-led assessment. A major goal for Proctera is to supplement local in-person learning and reduce the reliance of a developing program solely on transient outside resources, so that over time, training programs become sustainable and self-propagating. While developing the Zambian training program, they incorporated periodic U.S. radiology resident and attending physician travel to Lusaka to facilitate instruction and assessment, in addition to weekly teleconferences consisting of didactic and case-based teaching. Zambian radiology residents were also scheduled to rotate through the University of Rochester, 2 of whom were able to complete their scheduled rotations before the COVID-19 pandemic. In 2020, COVID stressed healthcare systems and limited travel worldwide, but at the same time, learning in the virtual space became rapidly more prevalent. Training programs shifted to remote learning, educational content became more available online, and web conferencing and social media have facilitated more opportunities for interinstitutional teaching. The authors state that they anticipate the usage of web conferencing by training programs will become more commonplace for lectures, case conferences, and readout sessions, and can more readily be adapted for interinstitutional and international use. The Proctera learning modules lend themselves well to this new era of increased virtual education. Developing programs and partnered U.S. institutions can more readily and more consistently share learning material online, allowing continuous education rather than discrete blocks of in-person teaching. This will minimize the reliance on people physically traveling to teach or learn on site. The authors express hope that Practera will be used in conjunction with available expertise and other online learning materials to meet the needs of a developing radiology training program with limited resources. They state that they will continue to build on this knowledge going forward and hope to collaborate with others in radiology who engage in global outreach and education as they work toward decreasing disparities in radiology accessibility and radiation education worldwide. The platform can be viewed online at www.practera.org, and that's spelled Practerra. Great initiative. That's it for this week's podcast. We'll be back in 2 weeks with more summaries.